Hello, everybody. Over the next 20-25 minutes, we will discuss the role of next generation imaging for redefining the oligometastatic state in hormone sensitive prostate cancer. Here are my disclosures. So we can think about oligometastatic disease as being an intermediate or transitory state between no metastatic disease and polymetastatic disease, where there is a window of opportunity for metastasis-directed therapies to have meaningful impacts in terms of delaying or even stopping the development of polymetastatic disease. And the first convincing demonstration of this comes from the Saber Comet study, which showed a 13-month improvement in overall survival for the CyberKnife treated patients. You can see that the majority of patients had less than 3 oligometastases, and that most lesions were either in the bones or in the lungs. So let's clarify some of the terminology around oligometastatic disease in prostate cancer. Generally, 1 to 10 metastatic lesions are considered to be oligometastatic, although most studies now have settled on between 3 and 5 metastatic lesions defined on conventional imaging. Visceral disease is usually excluded, so polymetastatic disease is more than 3 to 5 lesions, including visceral metastases. De novo metastases are metastases that are present at the initial presentation of prostate cancer. In other words, you have an uncontrolled prostate cancer in situ. The patient is obviously hormone sensitive. Tacreinous oligometastases occur sometime after the primary treatment has been undertaken. These people are also usually hormone sensitive. Oligo recurrence represents recurrence in the vicinity of a previously radically treated lesion. So this can apply to the prostate gland. And oligoprogressive disease relates to the emergence of a few metastases while others remain well controlled by therapy. And of course, MDT or metastasis-directed therapies is a focal or regional treatment of oligometastases, usually by radiotherapy or even surgery. So we can think of the oligometastatic states as being either hormone sensitive on the left or castration resistance on the right, with either a controlled or an uncontrolled primary tumor. So let's take an example of a metacrinous oligometastasis in a patient who presents sometime after external beam radiotherapy for a prostate cancer. You can see that there is a metastasis within the L3 vertebral body. We can see also that there's radiation atrophy below L4. This seems to be a oligometastasis on the basis of conventional imaging, which usually also includes morphological MRI. So is conventional imaging enough for planning CyberKnife radiotherapy in this particular patient? Well, if we look at the Oriole study where 54 men with oligometastatic disease based on conventional imaging to bones and lymph nodes were randomized 2-to-1 to either stereotactic radiotherapy or observations, we can see that the patients treated with CyberKnife radiotherapy had a better progression-free survival than those who were just observed and treated in the standard way. So this suggests that it is highly appropriate to treat this particular patient with CyberKnife radiotherapy, which is what was undertaken. But you can see over time that his PSA begins to rise, and on 2 follow-ups you can see he has developed polymetastatic disease sometime after the CyberKnife radiotherapy. The question that really arises is, would the use of next-generation imaging at an earlier time point have changed the long-term course for this particular patient? As we've already said, oligometastatic disease is defined by bone scans, CT scans, and morphological MRI, and next-generation imaging is looking before that. It's looking at this phase of the disease where there is microscopic metastatic disease. Most studies looking at metastasis-directed therapies have used CT scans, bone scans, and morphological MRI. We now see multiple studies evaluating either first-generation or more recent next-generation PET tracers. And what's been noted by almost every study is that there are significant reclassifications, both upstaging as well as downstaging, occurs when you use higher sensitivity imaging compared to bone scans, CT scans, and morphological MRI. And here's a classical example of how the tracer type affects the number of metastases. So you can see these two scans are done a few days apart, and you can see a few metastases on the choline PET scan on the left and widely spaced metastases in the PSMA PET CT on the right. So it appears that the tracer for 2020 is PSMA PET CT. And this has been also shown in meta-analysis. So this particular meta-analysis looked at the relative sensitivity of PSMA versus fluciclovine. For people with quite low PSA levels in the biochemical recurrence setting, you can see the PSA levels are less than 2 nanograms per ml. And you can see for every substratification, we can see that there is an increased pickup of PSMA PET CT over fluciclovine, but this is only really statistically significant when PSA levels are greater than 1 nanograms per ml. Of course, it's also important to look at the studies themselves individually, and this is a very nice analysis looking at 50 patients. And overall, again, we can see that PSMA has a statistically significant increase in pickup rates compared to fluciclovine. And again, you can see that at lower PSA levels, there's really quite a lot of overlap, but overall, it does appear to be performing better. And we see this for individual organs also. So we can see that in pelvic lymph nodes, in extrapelvic lymph nodes, bones, and other organs, we see a better pickup by PSMA compared to fluciclovine. And here's an example of a lymph node that's positive in the left pelvic side wall on the PSMA PET CT on the right side of this image and negative on the fluciclovine, which is on the left side of the image. But the situation is in fact reversed in the prostatic bed. You can see the fluciclovine appears to perform better than PSMA. So we really now are at the stage where we begin to see these microscopic deposits within normal sized lymph nodes, which all of us would have called negative on the T. So we believe what we see, and once we realize that there are false positives that do occur, then that makes us even more confident. However, it's not unusual to see this sort of situation where you've got bilateral metastatic disease and the PSMA PET CT does not pick up every lesions. We need to realize that all next generation imaging will understage patients when assessed against a strong gold standard such as surgical nodal dissections. So here is a recent meta-analysis that was published looking at the performance of PSMA PET CT scans for nodal metastases, and you'll see that there is only a moderate sensitivity of PSMA PET CT against the gold standard of a surgical dissection. This means that PSMA PET CT cannot be used to justify a limited treatment of nodal metastatic disease because the sensitivity is only moderate. On the other hand, if you look at the specificity, you see the specificity is in the 95 to 100% range, which means that we can use the PSMA PET CT to escalate or even extend a field of radiotherapy prescription. But because you can't treat what you can't see, there is a high risk of disease re-emergence if you only target treatments to lesions that you can see. Let me show you an example of this. Let's take a patient with metachronous oligometastatic disease. He's a 66-year-old man with high-risk prostate cancer, had prostatectomy with pelvic radiotherapy, and then undergoes biochemical recurrence, and you can see a left internal iliac lymph node just above the radiation field. This lesion is confirmed by the red arrow on the whole body MRI scan, and the treatment using cyberknife radiotherapy manages to eliminate this metastatic deposit. You can see that there's a gratifying fall of the PSA from 6.1 to 0.7, but you'll notice it's not 0. And over time, as you'd expect, new metastases begin to emerge, and in this particular case in the contralateral pelvis, both on the whole body MRI scan as well as on the choline PET-CT scan. So these two lesions were also treated with cyberknife radiotherapy. Again, the PSA falls and then begins to rise again, and then we repeat the choline PET-CT and we see two lesions. One lesion is just below the C loop of the duodenum, and the other lesion is just at the aortic bifurcation. So we treat these two lesions and the PSA goes down, but then rises again. And you can see this time we have a deposit in the left paraortic region, which is in the field of radiotherapy. For 6 years since biochemical recurrence, he's had no ADT, he's had 3 cyberknife therapies, 5 lesions treated altogether. He has a new biochemical recurrence, but this biochemical recurrence is an area of treatment, so what do we do now? Well, fortunately, we didn't have to make a big decision on this guy. He was put on ADT and shortly thereafter developed metastatic pancreatic cancer. So it was almost as if we were playing Pokemet in this particular patient. Taking this case consideration and the sensitivity and specificity data that I've already discussed, we can take away some important lessons. Firstly, because there's a high accuracy for ruling in the metastatic disease on the basis of the specificity, the high accuracy means that we can use therapy escalations to the identified site of the disease if it's beyond the normal boundaries. However, the sensitivity, you remember, was only moderate. That means we should be looking at either regional rather than lesional approaches, or if we're going to do lesional approaches, then we need to use some sort of systemic adjuvant treatment such as ADT. And so the STORM study will certainly assess this, which will look at escalating radiation fields by using whole pelvic radiotherapy also. All this calls for better evidence on how to manage patients using next generation imaging with their different accuracies and inherent stage migration consequences, which we will discuss shortly. So let's take another patient in whom we did really see a huge stage migration. This patient had what looked like oligometastatic disease at presentation. So here's a 55-year-old man, low PSA 3.3, abnormal DRE, found to have a Gleason 9 tumor in the left peripheral zone with T3A disease. Now he had conventional staging with a bone scan showing 2 lesions, but negative CT scans. So the question is, does he have bone metastases? Difficult to say if these are unconfirmed bone scan lesions. Is this oligometastatic disease less than 3 to 5 metastases on a bone scan and a CT scan? Clearly not. Should he have prostate radiotherapy and long-term ADT, which would be indicated for bone scans, CT scans detected oligometastatic disease, but not for polymetastatic disease? Should he have metastasis-directed therapies to these 2 lesions, which of course are unconfirmed sites of metastatic disease, or should we do next generation imaging to know what the hell is going on? Now, a lot of us will be tempted to do next generation imaging, as were we, and we showed that the primary tumor is PSMA avid. And straight away we can see a lesion in the right pubic bone. We can see that the right acetabular lesion was in fact a metastatic deposit, both on the whole body MRI scan as well as on a PSMA PET-CT scan, as was the left rib. And indeed, if you look at the MIP images, you can see that there were 2 lesions on bone scan, no lesions on the CT scans. The whole body MRI scan showed 10 lesions. The PSMA PET-CT showed 10 lesions. So this is real stage migration occurring as a result of the use of a next generation imaging technology. The question is, does this provide clarity about what to do with this particular patient in terms of a management approach? And I'm not sure that using imaging in this way actually helped decide what to do with this patient. using the charted criteria, he should be treated actively with pelvic radiotherapy and perhaps cyberknife radiotherapy to these two areas. And we certainly know that he would benefit from this approach, but we also know that he has polymetastatic disease, so we will be leaving disease behind. In other words, we have stage migrated this man from the oligometastatic state to the polymetastatic state, and this will have consequences in terms of lead time bias if the new information is not acted upon. So in other words, we need better evidence to show that the use of next generation imaging actually helps people survive better because there are better treatments that are deployed. Let's go back to the Oriole study. You'll remember in the Oriole study, 54 men with oligometastatic prostate cancer were randomized 2-to-1 to stereotactic radiotherapy or observations, and we had a better progression-free survival. But we also need to remember that 45% of people who had cyberknife radiotherapy had PSMA positive lesions that were untreated. We can see that cyberknife radiotherapy had its greatest benefit when there were no untreated lesions left behind on the PSMA PET-CT. Indeed, distance metastasis-free survival was greatest for men who had no untreated lesions, and men who underwent cyberknife radiotherapy for all visible lesions had the lowest risk of developing no new lesions within the next 6 months. It's interesting to also see that if you had a lower burden of disease, that you were less likely to develop new disease in the next 6 months. If you want to achieve better cancer-specific survival, better symptom control, reduced toxicity, and a delayed initiation of systemic therapies, you are going to have to use next-generation imaging because comprehensive metastasis-directed therapies guided by next-generation imaging can reduce the risk of the development of polymetastatic disease. But you need to use the right treatment based on the new information that you've gained with next generation imaging. So here are my conclusions. It's clear that conventional imaging misrepresents the true burden or activity of the disease, and next generation imaging is shrinking the oligometastatic state, which I think in the future will have to be defined by next generation imaging. We now realize that next generation imaging will lead to management changes that could positively impact on overall outcomes. But we need direct and high-level evidence to support the improved oncological benefits using next generation imaging. And we all await multiple randomized studies that are investigating this concept. Thank you very much for listening. Leave me some comments.